Hello everyone, very happy good evening to hello everyone, very good evening to everyone present here. A very warm welcome for all the delegates who have joined us, speakers, and also Professor Peter Hillman for joining us today for this session. So on behalf of AstraZeneca, I extend a warm welcome to all of you. Hope you're all safe and doing good. So today we are going to discuss on the chronic lymphocytic leukemia about the current practices and how we are going to see the future about this management. So I will hand over to Dr. Poonam Patil. Dr. Poonam Patil is a medical oncologist from Manipal Hospital from Bangalore. She has over 33 years of experience and has authored more than 20 publications, and she will be moderating the sessions for today. Welcome, Dr. Patil, and I hand over the baton to you, ma'am.
Thank you very much, Doctor. Welcome to you all. And we are very delighted to have this today's symposium. As we were all taught initially in our MBBS days that chronic lymphocytic leukemia is a disease that you will live with but would not die of it. That was the thought many, many years back. But later on, we came to know that there were, I think that was because we didn't have good medications for CLL. And so that is what the teaching was at that time. But later on, as more and more about the disease biology was known, it was realized that it is not truly so. And CLL needs to be treated at some point of time. And there are drugs available now for treatment of CLL. Initially, it was traditional chemotherapy, oral, intravenous, targeted treatments, but we have come a long way in the journey of treatment of CLL. And today we have this educational symposium sponsored by AstraZeneca, and we are delighted to have Professor Hillman amongst us, and who will be giving us a talk. And welcome, Professor Peter Hillman. So a little bit about Dr. Hillman. He studied in medicine at Leeds Medical School in 1985, and since then has occupied many prestigious positions. And he has research interests in both paroxysmal nocturnal hypoglobinuria and CLL. And since 1990, he has continued to research into PNH that eventually led to the development of anti-complement therapy for PNH. So that was something path-breaking. He was the lead on the trials of eculizumab and now leads the National PNH Service based in Leeds and Kings. The National PNH Service looks after over 300 patients with PNH, and this provides a unique resource for continued research into the pathophysiology and therapy of PNH. Since 1995, he has been keenly working in therapies for CLL. His group has pioneered the use of minimal residual disease assessment in CLL, and he chairs the NCRI CLL subgroup in the UK, which is responsible for the development of UK CLL clinical trials. He initially studied the chemoimmunotherapeutic approaches for CLL, but recently the development of targeted small molecules, particularly of the B-cell receptor pathway and of apoptosis, has led to a dramatic change in the treatment of CLL. His research is now focusing on the mechanism of action of these targeted therapies in order to maximize their potential. So welcome, Professor, and I invite you to deliver your talk.
Thank you. Thank you very much for that kind invitation. I'm going to try and share my screen, I think. That's the way to do this. How is that? Can you see? Hopefully you can see the screen.
Yes, sir.
Okay, very good. Okay, it's a pleasure for me to, unfortunately I can't be in India with you. I've enjoyed my journeys there in the past, but hopefully in the future, when we get through the current crisis, we'll be able to go back to normal traveling, and I'll be able to visit you. So it's my pleasure to talk about our experience with specifically Acalabrutinib in CLL. These are my disclosures. As you heard, we've done a lot of trials, particularly in new therapeutics in CLL over the last 10 or 20 years, and certainly the world of CLL has changed dramatically to the extent now chemotherapy is becoming a thing of the past in terms of the trials we're doing, and we're now on to obviously next generation drugs, of which Acalabrutinib is the first to be approved, I think, for the BTK inhibitors, and I'll talk in more detail about that. I'm going to present this with 3 patients. These are 3 of our patients from the many patients we put in the Acalabrutinib trials to just demonstrate some of the issues and some of the benefits of this type of therapy. So the first patient is a gentleman who is now in his 60s. He's a retired publican who initially presented in April 2015 with a cough and swellings in his neck. No previous medical history of note, and he was on no therapy at the time. And you can see his blood count there. He had a moderate lymphocytosis, but otherwise relatively well preserved count. He actually presented to an ENT surgeon. So despite having an immunophenotype in his peripheral blood, which is typical of CLL, 5 positive, 23 positive, and we tend to find CD200 and ROR1 being very strong markers for CLL. He had a lymph node biopsy, a needle biopsy, which again, not surprisingly, was replaced by CLL and was not transformed. So at this point, he had stage B disease, did not require therapy, was not too symptomatic apart from his moderate lymphadenopathy. Soon after his presentation, he was actually admitted the next month under cardiology with a shortness of breath and fast atrial fibrillation. So he hadn't had any therapy at this point and was commenced on digoxin, bisoprolol, and rivaroxaban to control the rate. He had a cardioversion 2 or 3 months later and did convert to sinus rhythm, but unfortunately reverted back to atrial fibrillation almost immediately and had to be commenced on ramipril as well as the other 3 drugs mentioned above. So he, about 9 months after his presentation, his lymphadenopathy progressed. So he now has 4 to 5 centimeter nodes in his neck, in both axillae, and spleen wasn't enlarged. You can see his lymphocyte doubling time is in the region of 4 months. So it's doubled twice since his presentation. Although his hemoglobin is well preserved, his platelet count has now started to fall. We would routinely, this was in 2015, so we weren't doing next generation sequencing then. We are now for our patients, but he had a VH mutation status. He's mutated, had a biallelic deletion of 13q. We find in our practice actually probably the biallelic deletions are worse than the monoallelic deletions of 13q, but he had normal chromosomes 17, 11, and 12, and his p53 sequencing was normal, was wild type, so he wasn't p53 deleted. So he clearly now needs therapy. As I said, he has a relatively recent history of atrial fibrillation. So we elected to put him into the Elevate-TN trial. So this is, I'll show you the design of the trial in a moment, but a trial in which 2/3 of the patients got targeted treatment. This is in December 15. So thinking about acalabrutinib or calquence compared to ibrutinib, obviously ibrutinib has had a major impact on the outcome of patients with CLL. It's probably the single drug that's had the biggest impact on survival of patients, certainly in relapsed and recently in frontline disease. But one of the issues with ibrutinib is it's not completely clean, and it inhibits a number of other tyrosine kinases shown on the kinome map on the right. And you can see that the green is BTK inhibition, and then the red is the other tyrosine kinases that are inhibited. The size of the circle shows you how effective it is at inhibiting irreversibly these other kinases. And you see there are multiple different kinases that are inhibited. Whereas with the acalabrutinib in the middle, you can see that the BTK is well covered, but the other tyrosine kinases are less inhibited. There's about 4 that have significant irreversible inhibition, which we would hope would reduce the side effect profile. The Elevate-TN trial, which was presented by Jeff Sharman now over a year ago and published in The Lancet last year, was a 3-arm trial. So it's quite nice in that we have acalabrutinib with or without obinutuzumab compared to claramycin obinutuzumab. This was in patients considered unfit for FCR, which our patients certainly would be unfit for that, over 65 or with significant comorbidity. The median follow-up at the latest presentation, and we'll see more of this data fairly soon, but was 28.3 months, so relatively short follow-up for our phase 3 trials. And the trial was powered to show the primary endpoint being progression-free survival between the acalabrutinib arms and the clemizole obinutuzumab arm. It was not powered to show a difference between the two, the acalabrutinib with the acalabrutinib obinutuzumab arm, although obviously that the safety and depth of remission was studied. So the therapy is conventional. Acalabrutinib is given a dose of 100 milligrams twice a day. Obinutuzumab clemizole is similar to the CLL11 study, which led to the licensing of that combination. These are the 3 arms of the trial. So it's a reasonably big trial, 535 patients, median age 70 in the trial, which I guess is reasonably representative for our CLL patients. About 20% or 15 to 20% were less than 65 in the trial, the majority being over 65. ECOG 1 to 2, not to 1 in the vast majority. Mostly progressive stage, rise stage 3 or 4, or BNAC disease, or certainly BNAB disease. 17P patients were allowed to go in, but only a minority, as you can see, about 9% across the trial. PPD mutation at about 10 to 11%. So a relatively standard risk group for a frontline study. This is the progression-free survival outcome data, which is the primary endpoint. You can see in the green is the clemizole obinutuzumab arm with 47% progression-free at 2 years, which is about what we see early on in trials, maybe a little bit higher as we get a little later with the follow-up. And the 2 acalabrutinib arms were both significantly better, with a hazard ratio of 0.1 or 0.2, a p-value less than 0.301. As I said before, the trial was not powered to show a difference between the 2 acalabrutinib arms. The hazard ratio between them was 0.49, and the confidence limits did not cross 1. So it's of interest, I think, maybe something we can talk about, whether there is a role for adding obinutuzumab to BTK inhibitors. The patients did not stop therapy; they continued therapy until progression, even if they achieved an MRD negative remission. If you look at the depth of remission, you can see that the vast majority of patients respond. So 5% have stable disease, 85% respond to acala alone. If you look at the obinutuzumab combination with acala, similar very high response rates, over 90%. We're now seeing a portion of patients who are having a CR now. It may be a little bit early to see a CR with the acala arm at 28 months. You tend to see continuing improved response. And the obinutuzumab clemizole doing what we expect. So no great surprises in terms of a better remission rate for the combination compared to clemizole obinutuzumab. This is the overall survival, and again I say this is early on in the follow-up. Patients could cross over to targeted therapies if they progress. There's no difference in overall survival as of yet, and I guess that's not a bad thing, because you really don't want to have trials where patients are dying without seeing the novel targeted treatments that are making such a difference to the outcome for our patients. About just over half the patients had crossed over to receive acala from the clemizole obinutuzumab arm. Importantly, particularly with the mode of action of acalabrutinib, with it being a more specific BTK inhibitor, is the side effect profile. We're seeing emergent atrial fibrillation, other rhythm disturbances, occasionally ventricular tachyarrhythmias, and hypertension with prolonged use of ibrutinib. Depending on the series, 15% maybe of AF, even up to over half of patients developing hypertension with time. Now we have to remember that this trial is relatively short follow-up, so we're still collecting data, and this may well increase. But as you can see, the atrial fibrillation rate for the acala arms is around 3.5% to 4% of any grade, compared to only 1 patient in the clemizole obinutuzumab, and the hypertension rate is relatively low compared to the ibrutinib trials and in the real world. My experience of bleeding is there really isn't a lot of difference between the BTK inhibitors. We've used a number of them. I think this may well be a BTK effect, but it's certainly a manageable combination. We'll have to consider antiplatelet drugs with any of the BTK inhibitors. Infections are really driven by the disease, I think, rather than the BTK, and secondary primary malignancies obviously will be following. So the conclusion of the Elevate-TN from Jeff Sharman's paper and presentation is that both acalabrutinib alone or with obinutuzumab are significantly better in terms of PFS compared to conventional chemotherapy in this group, almost obinutuzumab. It's consistent across multiple different groups of patients, prognostic groups, and there's crossover which affects overall survival. I alluded to the fact that obinutuzumab we see deeper remissions, but we, as of yet, don't have definitive evidence that we should be combining obinutuzumab with acala. And certainly in the COVID era, we've been trying to avoid intravenous therapies. So going back to our patient, so he commenced acalabrutinib in December 2015 in the trial, 100 milligrams BD. He's had no issues tolerating it. His AF continues, but there's been no significant cardiac toxicity. He continues on therapy. You can see he had the expected lymphocytosis with lymphocyte count going up to about 230 fairly soon after starting acala, as you see with ibrutinib, and then this has settled down, and he's had a normal lymphocyte count now for at least the last 2 to 3 years. His platelet count has recovered, as is his hemoglobin, so he's tolerating his drug very well. We last saw him in clinic a couple of weeks ago, and his blood count is normal, and he's tolerating his treatment well. So that was the first patient showing that we're seeing now durable long-term remissions with acalabrutinib, and certainly it seems to be well tolerated even in patients with previous cardiac issues, as you can see, although we're still waiting for the head-to-head comparison of acalabrutinib with ibrutinib, which we expect to see sometime later on this year, which will, I think, definitively tell us whether there's a significant difference with the more specific targeted BTK inhibitors in terms of safety. The second patient is a chap who's now 69. He presented in 2013 with cytopenia. So his problem has always been prolonged and significant cytopenias, as you'll see. So at presentation, he presented with neutropenia, 0.4, hemoglobin of 51. His Coombs negative, it's not obviously hemolyzing, platelet count of 19. No lymphadenopathy, no splenomegaly. On the scan, he had low-grade lymph nodes and a very slightly enlarged spleen. His marrow and blood both showed a typical CLL, 5 positive, 23 positive, weak CD20, 200 positive. We went doing RAW1, 2013. And marrow showed that his bone marrow was completely replaced by CLL, explaining his degree of cytopenia. We weren't doing sequencing at the time, but his FISH was normal for 17p. And the decision at this point was made to treat him with FCR on the basis that we didn't have targeted treatment, of course, in 2013. And also we do see rapid responses with FCR. So we wanted to clear the marrow out as quickly as we could. So he commenced treatment, was admitted actually after both courses, but after the second course was admitted for 6 weeks with neutropenic sepsis. After the second course of FCR, he also developed fast AF and pulmonary edema while I was in, maybe due to the infection and his cytopenias. You can see his count, so he's now profoundly neutropenic, hadn't improved. His hemoglobin was 90 transfused, and his platelet count was in single figures. So we stopped his FCR as he was clearly transfusion dependent. We did a marrow and there was improvement, although there's still some CLL there. And over the next about 15 months, he generally improved, but was still requiring occasional transfusion. So this is something we see with FCR, this sort of prolonged cytopenias, particularly in patients where this was a problem initially. So by April 15, he recovered somewhat. So his hemoglobin was transfusion independent, hemoglobin 114, platelet count was 43. Marrow at this time was extensively involved again with CLL. And we were doing the first of the acala trials, the A001 trial, which is a phase 2 expanded number of patients trial, which he was eligible for. So of note, the ibrutinib trials excluded patients with platelets of less than 30. In fact, the acala allowed patients down to any platelet level, but he was just above 30 when we put him in the trial. So what data do we have for acalabrutinib in the relapsed refractory setting, so patients treated like our gentleman with FCR? Well, the ASCEND trial, which was presented by Paulo Ghia now a couple of years ago in 2019, but published in JCO in 2020, was the randomized phase 3 trial of Acala for relapsed refractory patients. So 310 patients were randomized between acalabrutinib at the conventional dose, 100 milligrams PD, versus either the physician's choice of idelalisib, rituximab, or bendamustine rituximab. The vast majority of patients, 119 of the 155 patients, received idelalisib, that had previous chemotherapy, and 36 had bendamustine rituximab. I'll show you the two splits. The primary endpoint of the trial was PFS, with on normal secondary endpoints including safety, and the eligibility criteria shown here on the right. So patients with prior therapy excluded if they were on warfarin, and also if they had a previous BTK inhibitor. But cardiovascular disease, if controlled, were allowed to go into the study. So the patients were, this is the demographics of the patients. So you can see the median age is a little bit younger than the Elevate TN, so 67, 68. Again, fit patients, the median number of therapies was either 1 or 2, depending on the arm, slightly more in the Idela and bendamustine arms. And the prior therapies are shown here. So most of them had PO analogs with or without a CD20 antibody. And the cytogenetic slightly more 17p deletion, as you can see, and about a quarter of patients having a p53 mutation. This is the outcome of the trial in terms of the primary endpoint PFS. So it's a significant improvement for acalabrutinib over both Idela and bendamustine rituximab. They're split up on this curve, as you can see. So the majority of patients in the control arm had Idela rituximab. The median follow-up is still relatively short, 16 months. In the latest follow-up, the hazard ratio was 0.31 in favor of acalabrutinib, which obviously is highly significant. And in terms of the interim analysis time point, only 17% of patients with Acala progressed, as opposed to 44% of patients in the control arm. If you look across the different disease groups and different risk factors, you can see there's really no difference with all risk factors, whether it be p53 mutated, unmutated, or mutated, etc., showing an advantage for acalabrutinib over the control arm, which is predominantly, as I said, idelalisib plus rituximab, with a small proportion having bendamustine rituximab. Importantly, the side effects, well, we see, as I showed you in the previous one, bleeding is an issue with BTK inhibitors. We do see a headache with Acala. I'll talk about this a little bit later on. So in the up to about 40% of patients with Acala will experience headache. This is usually with the first few doses, passes off within the first 2 or 3 weeks of treatment. Is often caffeine responsive. It's usually not a severe headache, which is more frequently seen with Acala than the control arms in this trial. Again, the cytopenias are better than chemotherapy, probably, or similar at least to chemotherapy. And SAEs were reported less frequently with Acala than with idelalisib, and similar to BR. And I'll show you the stopping in a moment. And in terms of deaths, only 5%. That's 5% of the Acala patients died at the latest follow-up, opposed to a higher proportion, 8 or 11% in the control arm. If you look at the grade 1 to 2 AEs, which is shown here, they're largely similar across the trial. With the bender, you see more fatigue with chemotherapy, but it seems to be well tolerated. And if you look at the grade 3 cardiovascular side effects, so AF particularly, or hypertension. So first of all, the AF rate is similar to what we saw in the frontline study, so about 5% all-grade AF rate with acalabrutinib, compared to nothing with Idela, although the treatment duration was shorter, and about 3% with BR. In terms of ventricular tachyarrhythmias, they've not been seen in any of the patients in the trial. We don't see that in the Acala trials generally. It's very low percentage with ibrutinib, less than 1% in my experience. And hypertension, again, about 3% of patients in total had 2 grade 3. So, although we'll have to remember this is relatively short follow-up of a median follow-up of 16 months, so we obviously need to follow this data. I'll talk a bit more about this a bit later on. In terms of discontinuation, what we see is what we've seen in the trials. Actually, about 10% of patients will discontinue Acala because of AE, but almost half of the patients with idelalisib, which is one of the major issues with particularly the pneumonitis and colitis we see with Idela, and about 17% with BR, and dose reductions are shown on the right. We don't often have to dose reduce acalabrutinib, maybe for drug interactions, but not usually. What about the trial? This patient went into the ACE-001. Well, we only have, I'm going to show you data from the treatment-naive group. This patient obviously had 2 FCRs. So John Bird presented this data at this year's EHA. This is the longest follow-up we have with a reasonably large number of patients with treatment-naive patients treated with acalabrutinib. This trial started in about 2013-14. So this trial recruited from 2014 to 2015. It was a non-randomized trial for treatment-naive and also cohorts of relapsed and Richter's, which we also presented previously. Initially with 2 different doses, twice a day or once a day. I'll talk about that a little later on. 99 patients were treated who were treatment-naive with a follow-up, median follow-up of 53 months now. This is the breakdown. So we see 17 deletion in this group in 10%, P3 mutation in 14%, the majority being VH unmutated, about 62% of the patients. So we look at the discontinuations, which I think is important because it tells you more about the side effects. And the reason for discontinuing, 6% stopped because of adverse events in the treatment-naive group, which is lower than we would expect for ibrutinib. There was 1 death, and then the other causes are shown of small numbers of patients. So most patients remain on therapy, a median of 53 months, so 86% of patients remain on treatment. If you look at the side effects, similar to before, we see headache in about just under half of the patients, but this is generally mild and short-lived. And we see bruising and bleeding issues in about 1/3 to 1/2 of patients, as you see with other BTK inhibitors. Hypertension in about 20% of patients in the longer follow-up, and atrial fibrillation at low levels. If you look at the side effects by time, when we see this with ibrutinib trials as well, most of the side effects tend to be in the first year. As you can see here, diarrhea, headache, definitely in the first few weeks of treatment, but then becoming down to really background levels by year 2 or even before year 2. In terms of hypertension shown on the right, again, you see hypertension early, but then you still see cases, as I guess we're following these patients up very closely. In terms of SAEs, we see a typical number of about 1/3 of patients having SAEs, the 2 grade 5 SAEs as shown here. And in terms of AF, shown here 5%, and no tachyarrhythmia, ventricular tachyarrhythmias, and a really low level of other complications. So this is clearly a well-tolerated drug. And we're waiting for the head-to-head, as I said before. In terms of response for treatment-naive, the majority of patients, 97% of patients responded in this study, and across all risk groups, a relatively small proportion having a CR. This is the event-free survival. So the conclusion of the frontline trial is it's obviously well tolerated and led to the development of the Elevate-TN and relapsed refractory randomized trials that we'll hear about later on this year. So our patient started acalabrutinib, but very quickly developed an extremely severe rash, in fact, almost discourating rash, and continued to be transfusion dependent with platelets and red cells. We stopped his Acala, but it turned out that the rash was due to his allopurinol, which had started just before. He was off acalabrutinib for over 2 months, and then restarted Acala without allopurinol in the end of June and had no further skin reactions. So you can see his graph here that he had FCR was profoundly cytopenic. So the lines moved slightly. So hemoglobin he was transfusion dependent. When he started Acala, he was transfusion dependent both of red cells and platelets with a single platelet count. When we restarted Acala in the end of June, his platelets were in single figures, but these recovered fairly quickly. And as you can see, we're now actually, I'm not sure, I concertinaed the graph, we're now out to February 21. He's tolerating his treatment well, no further atrial fibrillation, and his blood count is not quite normal, but is close to normal. Hemoglobin 162, platelets 120. So you can support these cytopenic patients through treatment. The final patient I'll show you, and then I'll just talk about one or two of the issues, was a more elderly patient, born in 1938, retired nurse, diagnosed in 2003 on a lymph node biopsy, was watched for 5 years until she became progressive. At that point, we had this is May 2008, we had one of our UK trials open and she was treated with cloramicin plus rituximab. This has been published, and she had a good remission, although it was MRD positive. This lasted for about just under 6 years before she needed treatment again. And at that point, she was had progressive disease, symptomatic disease, and needed ibrutinib. So she started ibrutinib at a conventional dose. We just had approval on an expanded access program at this point, and she had really quite bad diarrhea, grade 2 to 3 diarrhea, and quite bad arthralgia. She was quite a keen golfer and struggled with arthralgia. We reduced the dose of ibrutinib with no improvement in the symptoms, and eventually, after about just under 18 months on treatment, she stopped her ibrutinib permanently. At that time, she was in a good remission of a CLL, was clinically well. By July 17, so just about 24 months later, she started to progress with symptoms, although her counts were reasonable, and her marrow was extensively involved with CLL. She's now developed a 17p deletion, and she's VH unmutated. We didn't have that data before, and she was entered into the 208 trial, which was an Acala switch trial from ibrutinib intolerant patients for Acala. So what about the results of the 208 study? So the 208 study, as I said, was for patients who had ibrutinib and switched off ibrutinib, not for progressive disease. As you can see, this is the outcome. There were 60 patients treated within this trial. The latest follow was 23, almost 2 years follow-up. We saw reasonable response rate because these patients have failed ibrutinib before. You can see in the blue column the patients who discontinued, the reasons they discontinued, so 16 for AF, 7 for diarrhea, etc. That's the reason they discontinued ibrutinib. And for the most part, these side effects did not reoccur, or if they did, reoccurred at a lower severity than those on ibrutinib. So these are the sort of nuisance side effects largely, with some cardiac side effects. And the median follow-up, at this point, over half the patients remained on therapy, with only 7 patients of the 60 stopping because of AEs due to acalabrutinib. So suggesting we can switch from ibrutinib to Acala for these sort of nuisance side effects rather than progressive disease, which is a different issue. What we saw in this trial were the typical side effects: headaches, a small number of cardiac events, and the bleeding, which we sort of expect. So our patient entered 208, was started on Acala, so now she's sort of 14 years into a CLL journey. She had occasional headaches, which responded to paracetamol and resolved within a couple of weeks. She did not have return of her diarrhea initially, and a very good response clinically and radiologically. This was her count by August 2019, so she was in a good remission with an essentially normal blood count and a bone marrow with 12% CLL, which we wouldn't normally do in follow-up, but she was in the clinical trials. This is to assess CR or PR. So she's in a good partial remission. She has a son who lives in the north, in Cairns in Australia, which is tropical. She travelled there every year, went to Australia, came back with a mild eosinophilia, which we haven't seen before, and that progressed over the next 6 months with weight loss and severe diarrhea. We thought this may have been Acala. We stopped it. Eventually, her eosinophilia got worse, up to 18, and the colonoscopy suggested that she probably has strongyloides, was treated and was off acalabrutinib for several months. She restarted this in October as the disease was now progressing again. Its eosinophil count was coming down, and she tolerated it well and seems to be responding well. So we can switch patients who are intolerant from a first-generation BTK inhibitor to acalabrutinib. So I thought I'd just over the last 5 or 10 minutes just go through some of the sort of frequently asked questions with acalabrutinib and how that fits in with our other therapies. So the first difference between acala and ibrutinib is the twice-a-day dosing rather than once-a-day dosing. Why do we have that? Well, that's really to cover the targets. As you know, the ibrutinib has a relatively short half-life but blocks BTK irreversibly, so stays within the tumor. If you look at the dosing, we don't have a comparative between once or twice daily ibrutinib versus acala, but on the right you can see the difference between once a day acalabrutinib in purple and twice a day, and the trough blockage of BTK is reasonable with once a day, but much better with twice a day, where you're getting very good coverage of BTK. Certainly the trial data has shown that this is an effective dose used, in my experience is well tolerated. So the recommended dose going forward is twice daily. Certainly I think for the more proliferative patients this is probably important. What about cardiac events? This is a key importance as these patients are likely to remain on a BTK inhibitor for a prolonged period of time until disease progression, although we're looking at combinations and intermittent treatments at the moment. So if you look across the trials, these are the 3 large trials I've shown you the data of. So Elevate treatment naive, the Ascend Relapsed trial, and the treatment naive frontline study, CL001. You can see that the rate of cardiac abnormality is in the region of 15 to 20% across the 3 trials with the acalabrutinib arms. Atrial fibrillation up to about 5%. Depending on the study. The longest follow-up is on the right, the Acala 001 trial, and we haven't thus far seen any ventricular fibrillation or other serious ventricular arrhythmias, and the duration of exposure shown here. So we really need more information comparing ibrutinib with Acala, but certainly with the data we have as it's maturing now, we're seeing low levels of both hypertension and cardiac arrhythmias with Acala, and the ACE-06 trial, which is the Elevate Relapsed Refractory, is a head-to-head comparison of ibrutinib versus acalabrutinib. And we're expecting to see that data sometime this year. We will see it sometime this year, probably at EHA or ASCO, and that's going to compare the 2 drugs head-to-head in the relapsed refractory setting. What about bruising? Well, I've said as we went through, that we see bruising and bleeding. It's a class effect, and I think it's due to BTK. We tend to see it worse in the first year, as you can see on the right, bruising 23% in the first year, but going down as the patient's platelet count improves and the disease comes under control, and relatively infrequent as we go later on. But it's obviously important around operations and the like, and that's consistent throughout the trials that I've shown you. So I don't think there's any difference between Acala and ibrutinib in terms of bruising or bleeding, or in the way we should handle it around procedures or other events. The headache is, I'm not clear why patients get headaches. It's not a feature of the other BTK inhibitors we've used, but in a pooled analysis which we presented by Rick Furman as the lead author at last year's ASCO of over 1,000 patients treated with acalabrutinib across different malignancies, headache was the most frequently reported complication, 38%. The vast majority were grade 1 or 2. The median duration was in the first 2 or 3 weeks of treatment, and only 1 patient of those 1,000 discontinued due to headache. So what we find is that simple analgesics, paracetamol, or caffeine supplements are effective. So even drinking coffee can definitely improve the headaches. Infections, well, this really again is a feature of CLL. There's no real difference between Acala and the other BTK inhibitors. We don't see profound neutropenia in many patients treated this way. So you can see typical CLL type infections. Maybe the addition of obinutuzumab, this is from the Elevate TN, may have an impact on pneumonias and sepsis, but with acalabrutinib alone, certainly in the front line, we're not seeing high levels of infection. About 15% of patients in the 001 study, which is the longest follow-up, had a grade 3 or greater infection during the follow-up of the study. In terms of prophylaxis, in frontline, my practice is not to use for prophylaxis unless there's a reason to do so. In patients who have chemotherapy, certainly for the Darwin-based, we tend to use cotrimoxazole and acyclovir if patients can tolerate it. The nuisance side effects, which I think for about maybe 20% of patients who have a real issue, maybe slightly higher, of diarrhea, arthralgia, and rashes are shown here. That's really not a major issue with acalabrutinib, and I've shown you the data from 208. We frequently switch patients from who have had these nuisance side effects from ibrutinib to acala, and they've improved. We have no experience of doing it the other way around. Of course, we assume this is due to the more specific nature of the BTK inhibition with acala, and we've certainly seen that with the other BTK inhibitors such as zanubrutinib or tirabrutinib, which are also more specific inhibitors. So that may give an advantage certainly for those patients who have trouble with these side effects. So in conclusion, acalabrutinib is the first of the more specific irreversible inhibitors of BTK that has now been approved. We've now got reversible inhibitors which are coming through trials as well, which are of interest for the more refractory patients. Certainly they're highly effective in acalabrutinib is highly effective in frontline and in relapsed CLL. Certainly in patients who have had ibrutinib and have stopped ibrutinib because of intolerance, particularly with the nuisance side effects or cardiac side effects, I think switching to acalabrutinib is sensible. I would not say the same about patients who have progressed through ibrutinib, because we haven't seen high response rates in that, and biologically the relapse is likely to be similar. And we encouragingly have seen significantly lower, in terms of clinically significantly lower levels of atrial fibrillation, hypertension, and we haven't seen any ventricular tachyarrhythmias in the acalabrutinib trials. We really need more data on this, and the head-to-head trial 006 will, I think, hopefully address the relative safety of acalabrutinib over ibrutinib. We'll see that data fairly soon. This is the abbreviated prescribing information, which I'll leave up for a second. I'm sure none of you, if you can access this as you need it. And then just finally to thank you for your attention, and I'm happy to take any questions. Thank you.
Thank you very, very much, Professor Hillman. And it was really a very good talk and sharing your experience with acalabrutinib in the CLL patients. Thank you very much. We all learned from it. Now, a few questions in the question box. Was how is the incidence of atrial fibrillation, hypertension, or infection in real world compared to clinical trial? Is there a significant difference like ibrutinib?
Yeah, I think it is. Our experience is that there is less atrial fibrillation and hypertension in the real world with acalabrutinib. We've treated probably 100 plus patients in the trials in Leeds across mainly CLL or Waldenstrom's, and we've had access to acalabrutinib as a expanded access program, now NICE approved for probably the last year. And so we've got quite a lot of experience using it outside of it. And there's also some real world data from America since it's been approved there for longer. And we see low levels of atrial fibrillation and low levels of hypertension. I have to say that we can usually manage it with ibrutinib. And I think the key in terms of which drug will be preferred for all patients is going to be the randomized trials. The 006 study, which I mentioned will be presented at the summer meetings, is a head-to-head with a large number of patients followed up for a long time, and that's going to be a really informative study, I think, in terms of safety. But I think the general feeling is the more specific inhibitors, certainly for CLL, are less toxic.
You had so many patients now with CLL last year who, during the COVID times, since immunocompromised patients on treatment, was there any difference in these patients compared to other patients? Yeah, I mean, it's been a real challenge. I mean, as you've also had in your country, but certainly in the UK, we've had a major problem with, in terms of, especially with the new variant now,
in the UK, which has taken over really. Certainly CLL patients are vulnerable, there's no doubt about that, and our patients have been shielding for most of a year actually, but many of them. In fact, we've been in lockdown for the last 6 weeks. We don't have a lot of data to look at Acala, but when I look at for example the FLIR trial, which is a trial in the UK with 1,500 patients in CLL, ibrutinib or FCR based treatments, what we found is we've had 31 proven cases of COVID in those 1,500 patients, and we've had 5 deaths at the last count amongst those patients. Patients treated with FCR are much more vulnerable. So of those deaths, 3 of the 5 were in FCR, and only a minority were treated with FCR. And so chemoimmunotherapy has undoubtedly is a bad thing to have if you get COVID. In terms of BTK inhibition, I don't think it may be protective. It's certainly not deleterious to people with COVID. As you probably know, there are trials of the BTK inhibitors in COVID as a therapy to see if it benefits non-CLL patients. My experience in CLL is that it's certainly not. It's not making the disease more severe. Our practice has been if someone gets COVID on a BTK inhibitor, we continue the BTK inhibitor unless they are heading towards a sort of critical care situation where we might want to put lines in or intervene, in which case we stop it because of the issues with the antiplatelet effect. So I think we're relaxed.
The next question is, what is your experience of acalabrutinib monotherapy and in combination with anti-CD20 inhibitors? The relevance of MRD negativity in acalabrutinib therapy, do you follow such a practice?
Yeah, they're really good questions that are very difficult to address. So I'll try my best. So I think just think about CD20 antibodies with BTK inhibitors generally. Rituximab, I don't think has a role. But obinutuzumab is clearly a more effective antibody in CLL. Initially, there was some concern that the BTK inhibitors might affect the effectiveness of CD20 antibodies. I don't think there's any evidence of that. There was some laboratory data. The only data we have really is from the Elevate-TN trial, which I showed you. We had a number of patients in the Acala in all the 3 arms, and the depth of remission is definitely greater with the combination. So we see a better, more MRD negative patients. We very rarely see it with BTK inhibitors alone, Acala or ibrutinib, but with obinutuzumab, we are seeing, in fact, 2 of my patients, I think, are MRD negative in that arm of the trial. The issue is that within the trial, we're not stopping the BTK inhibitor. So we're seeing MRD negative patients and we're continuing in the trial Acala. Now, I suspect we could stop it and the patients would probably stay in remission for a prolonged period of time. So as things stand at the moment, I don't think we can recommend obinutuzumab. I would not recommend obinutuzumab with acalabrutinib unless we're able to stop therapy. And I think that probably in the future will be the case, but we haven't got the trials yet, and they're not, certainly not anywhere near being presented, the trials which will address that question.
Thank you. There's another question. How would you differentiate acalabrutinib from other novel therapies like ibrutinib, venetoclax, based on your real-world experience?
Yeah, so I think the for that ibrutinib is relatively straightforward. I mean, it's a more specific inhibitor. It's twice a day, which is slightly disadvantage over ibrutinib. But in my opinion, there are less cardiac side effects and nuisance side effects. So I think that's relatively straightforward. I think if someone's intolerant to ibrutinib, then I would definitely try them on acalabrutinib rather than switch class of therapy, because in CLL, BTK inhibition is the therapy that's made the biggest impact on survival, and so I wouldn't lose that whole class of therapy. Whether we start Acala by preference, well, one certainly would if they had any suspicion, anyone with cardiac disease or hypertension previously, and maybe for all patients, we'll see what the 006 trial shows. In terms of venetoclax, the advantage of the venetoclax combinations is that they are relatively short duration therapies, 1 to 2 years, and we stop treatment. So that has clearly some advantages, both pharmacoeconomic and for patients, and in terms of the evolution of resistance. The disadvantage of venetoclax based treatments is the monitoring we have to do. So we're doing we treat a lot of people with venetoclax, obviously, and we're doing, the first 5 weeks, you've got a lot of monitoring, a lot of visits to the hospital, and then the infusions as well, because we give it with CD20 antibodies. And certainly in the COVID era, that's been a major issue for us. And so I think the choice between Acala and Ven-O or Ven-R is very much a patient-specific discussion. Do you want to have a more intense approach now and then have a period of time off treatment, potentially even very prolonged, or would you have a simple therapy that's well tolerated to control the disease? The other thing I should say is that the evidence we have, and it needs to emerge, is that you can use either therapy either way around. So if you fail venetoclax, you'll respond to acalabrutinib or ibrutinib. If you fail a BTK inhibitor, you'll respond to venetoclax-based treatment. And finally, I think the combinations are looking even more interesting of the two together, a BTK and a BCL2.
So for these various side effects that you see with acalabrutinib, do you give some drug holidays?
We haven't done that unless unless there's been a reason to start to do it in individual patients, and really we've had that very rarely. So the only one that we see is headache, and we counsel the patients before. We prepare them with caffeine and things to take if they need it, and really it's not been a major issue for the majority of patients. So we haven't had to take drug holidays. There's a little bit of an issue with proton pump inhibitors and affecting the absorption of Acala. So patients who are on lansoprazole, in our case, we tend to try to use an H2 receptor antagonist, but there's obviously ranitidine is not available now, so that's a bit of a challenge. So we've got nizatidine, which we use. So they're the only group of patients we've sometimes struggled with. We do give lansoprazole if they really need it, and it doesn't really stop the effect of Acala, but it's relatively contraindicated.
What about prophylaxis for fungal infections? You spoke about infection prophylaxis. What about fungal infections?
Yeah, we don't generally use fungal prophylaxis. Certainly with any of our CLL therapies, even in second, third, subsequent lines, I think if a patient's had a previous fungal infection, it's a challenge. I've just had a patient actually just now who's got cerebral fungal abscess, who's had long use of steroids for other reasons. So I think a patient on steroids and any therapy for CLL is a worry. The issue with fungal prophylaxis is the interactions between voriconazole, which is probably the one that you would use, and abrutinib and acalabrutinib is significant. So we've used ivosuconazole, which has slightly less interactions. We've used lower doses of ibrutinib in that setting. So you can give it, but I wouldn't use it as prophylaxis unless someone's had a deep-seated fungal infection before.
And drug interruptions during bleeding or surgery? Mm-hmm. The first year, the bleeding manifestations were much more compared to the later years.
Yeah, I think you have to be very careful with any of the BTK inhibitors. I think this is a BTK effect rather than an ITK or one of the other tyrosine kinases or TEC kinase. I generally would say to patients, if there's a risk of bleeding with a procedure, you should stop it. If there isn't, you can put your finger on it, then you don't need to. If it's a simple thing like a dental extraction or a minor endoscopy that needs a biopsy or the like, 3 days before, up to 3 days after, depending on what they've done to you. For a major procedure, 7 days before, 7 days after. If someone has an acute requirement for surgery, appendix or trauma, then we give platelet infusions and then omit it until the patient recovers 7 days later.
Okay. And for atrial fibrillation and new thromboembolic events, what is your choice of anticoagulant? Yeah,
so fortunately, that's obviously a bigger challenge with ibrutinib, although we see it. So we would anticoagulate patients. So we would tend to use apixaban, so DOAC, rather we wouldn't use warfarin-based treatment. Apixaban slightly because it's less gastrointestinal issues, and we can modify the dose a bit easier because of the 5 or 2.5 twice a day, although I don't think there's any evidence that any of the other novel oral anticoagulant drugs will be any different. So we would use that.
Any role of BTK inhibitors in Richter's transformation?
That's a really good question as well. So in the 001 trial, there was a cohort of patients with Richter's, and we did see responses. In fact, we had a really interesting patient that we had in that trial with developed Richter's through ibrutinib, had a 15 centimeter mass having failed platinum, and we put her on Acalabrutinib in the trial, and within a day it went down to 3 centimeters. It was amazing, and it responded, but the response isn't long lived, so it lasted 2 or 3 months. So alone, it's certainly not going to be adequate. We are doing a trial actually in the UK called Stella, which is for new Richters. It's CHOP-R plus or minus Acala, and so we'll see if that works. I think it has a role, but probably not as monotherapy.
Okay. So we'll take this last question. What is your view on finite therapy with acalabrutinib in combination with other novel agents?
I think that's really the sort of key question going forward. I think, you know, I'm more comfortable with continuous therapy with Acala over a prolonged period of time, because we set in frontline, because we're not seeing the level of intolerance that we can see with other BTK inhibitors. However, there is a potential issue of resistance, which is less so with frontline, but certainly in relapse. And obviously, from a cost effectiveness perspective, it's a challenge to give patients therapy indefinitely. I think the combination of a BTK and a BCL2, we're seeing really deep remissions with that combination. We're seeing 3/4 MRD negativity across numerous trials with different drugs within those classes, and durations of therapy of 1 to 2 years and stopping the treatment. So I suspect for the patients where we really want to have a dramatic impact on the depth of disease and potentially cure patients, or at least for a long time off treatment, those combinations will prove to be cost effective, because you're using 2 expensive drugs for a year or 2 and then you're stopping, rather than continuous therapy and switching therapy. With those trials are now, the phase 3 trials will report in the next probably 1 to 2 years, compared to chemo and to single agent drugs, probably 2 years for the combinations with ibrutinib and the Acala a bit later. So we'll have that data fairly soon.
Thank you very much, Professor Peter. And now we move on to actually what was supposed to be the first talk for the day. How do I manage my CLL patients, current treatment and challenges in Indian context? And I flipped it. Sorry, Dr. Ashish, for the inconvenience caused. And I am very happy to introduce Dr. Ashish. He's my colleague in Manipal Hospital. He's a member of multiple societies, both national and international. He has got many awards and achievements to his credit. And he and Dr. Amit established the bone marrow transplant unit at Manipal Hospital, Bangalore in 2004, which has been running very successfully. And his field of expertise, you all know, he's in hematology and hematology as well as bone marrow transplant. Dr. Ashish, I welcome you. And sorry once more, please go ahead with your talk. We'll go to the current treatment and challenges in Indian context. We heard, Professor, about the expert guidance on management of CLL with acalabrutinib. Now we'll look into the Indian context.
Thank you, Dr. Poonam. I think I'll just share my screens. All right. Are you able to see my screen?
Yes, sir. Put it on a slideshow mode.
All right. Thank you, Dr. Poonam. And I think what my talk today mentions is what do we do in India? And part of my talk actually is going to mainly concentrate there only. So what we know till now from Professor Hillman's talk is where we are going to actually end up as affordability gets better and we end up having more and more advances on the therapy. So we'll come down to what we actually do in Indian context, and we'll see how exactly we will go forward in that. The main difference in terms of what we see in India versus what we see in Western world is in terms of main 3 major parts. We see more cases in US, 21,000 approximately every year. We see most cases with the median age is around 71 years, so they are relatively older. Very few are less than 55, and majority die because of direct cause of the CLL itself. In contrast, if you look at the India, the major differences are in three main components. We have a decade earlier median age of presentation, which is around 60 years. These are the data which are usually come from two main centers. The data from All India Institute of Medical Sciences. In terms of number, that is another difference. We look at the first publication that was 18 years data of 510 cases only. That is very limited
Hello,
case.
Dr. Ashish.
Yes.
Sir, sorry to interrupt. Please turn on your video, sir.
It is on.
We cannot see you, so that.
All right. Let me check. Can you see the slides otherwise?
Slides we can see, not an issue, sir. Yes, now it is okay. Now
Now it's okay? All right,
now
fine.
the video got off again, sir.
All right, no, because I am actually presenting from the iPad, so it may be presenting only one thing
No
at a
issue, sir.
time.
No issue. Go ahead. No.
Sure.
Go ahead.
All right. So the difference, what I was talking about, is the age of presentation is a decade earlier. The number of cases are very few, which actually require therapy. So in terms of the number, and the third major difference is most of the cases can't afford. So that's what decides about in terms of difference in how we manage in India versus abroad. What we have understood till far, and I mean so far, in CLL is the value of prognostic marker. So we know the deletion 17p is going to be bad. We know that the deletion 13q is going to be one of the very good risk disease. Fortunately, this is the most common one, and deletion 17p is less common. Deletion 11 is somewhere in between. Now, if you look at the other parameter, which is IGHV mutated area, the IGHV mutated one usually do much better compared to what we see with the unmutated one. So these are the two parameters which is already known, and that was known even before the novel targeted therapies came in. Now, this is what is the standard in the NCCN guideline, what we should be doing in terms of the treatment for CLL. The preferred regimen is the targeted regimen, agents now, whichever category we go to, whether it is frail patient with comorbidities or it is a younger patient with no more comorbidities. The treatment has evolved into a targeted therapy. If we can't go for these because of contraindications or other reasons, then in that case, we will go to the standard one, which we were using for a long time. So this is what is essential difference between Western world and India. If somebody can afford everything, I think the treatment will not differ from what exactly is going on abroad. And as per this guideline, if the cost is a limitation, then we'll have to choose from a gamut of the other therapies which are available. Based on that, chemoimmunotherapy is still forming the cornerstone there. Now, same thing goes for a relapsed refractory disease. Again, targeted therapies are on top along with PI3 kinase inhibitors. The recommended regimen always will be in terms of chemoimmunotherapy, whether it is young or the old case. Deletion 17p is altogether different. I mean, at all. I mean, in terms of the preferred regimen, we very well know that the chemoimmunotherapy is not going to be as effective. So if somebody can go for a targeted therapy, it will be the best therapy. Otherwise, their outcome is not going to be too great, even if we try whatever other therapies we have in hand available. So ibrutinib or BTK inhibitor, acalabrutinib, any of these are going to be one of the way forward, or venetoclax. These are the preferred therapies going to be. So we'll just cover in short what we have achieved and what we already know about the chemoimmunotherapy as well as BTK inhibitors. We'll be concentrating mainly on ibrutinib because acalabrutinib data we have already seen. And what we know, acalabrutinib is going to be performing much better compared to ibrutinib when we look at the data. So this is a symptomatic CLL patient of 74-year-old with bulky lymph nodes and neck, axilla, and groin. Blood counts are reasonably stable with WBC of 88,000, predominantly lymphocytosis, confirmed diagnosis of CLL, first time diagnosed. widespread adenopathy, so is reported late with bulky lymphadenopathy elsewhere. And there is a deletion 11q on the FISH testing with the unmutated IGHV isolated. So this is the background on which we need to treat this case. Now we'll have to start right from beginning, from where BTK inhibitor came in the picture. So in general, we are going to use chlorambucil because it is a elderly person who cannot go for a chemoimmunotherapy, the other chemoimmunotherapy. So if you look at the trial, first was Resonate 2, where actually ibrutinib came in picture. We see the difference in terms of ibrutinib versus chlorambucil. Ibrutinib performed much superior with a 5-year survival going up to 70% compared to with the 5-year survival compared to chlorambucil, which we see very much lower down the ladder. Now that specifically says that actually this is why we need to switch over to the targeted regimen there. However, most of these cases were allowed to switch over to ibrutinib at the time of progression. So that's why the overall survival was not looking that different comparatively in between the two arms. What we know already, the major side effects related to ibrutinib, hemorrhages, fibrillation, and hypertension. What is important, it doesn't come down over a period of time. It remains more or less same with the same frequency that is coming every year. So some of these are quite difficult to manage, and that's where we need more targeted BTK inhibitor that is to be available. The similar trial, we needed a better immunotherapy, which is also available. So obinutuzumab with ibrutinib was added compared to chlorambucil, which is already easily available in our country. When we look at the combination, again, this was a similar population. Ibrutinib, obinutuzumab worked much better in terms of progression-free survival in Illuminate trial. At the same time, the same mechanism was there in this trial also. There was a crossover allowed on the disease progression. Overall survival did not differ. Now, these trials did not give a detailed analysis for the mutated versus unmutated one in the initial phase. This is an alliance study, so we are looking at, we can still use bendamustine rituximab in some of the older cases who are relatively fitter. Why not try that? So this was an interesting study comparing 3 arms, ibrutinib rituximab, or bendamustine with rituximab, mainly to check which one works better and are they similar to each other. The patients with bendamustine arm were allowed to cross over to ibrutinib within 1 year of progression of the disease. So if we look at the results, progression-free survival of both ibrutinib and rituximab arm were similar, and they were superior to bendamustine arm in terms of the PFS. However, there was no difference in between the two arms. Ibrutinib rituximab performed exactly same. In terms of side effects, it was on the expected lines. You see more hematological toxicity with bendamustine compared to more risk of hypertension with ibrutinib. Fibrillation, surprisingly, was not a major concern in between the two arms here. What about venetoclax? So much discussion we have has taken place about this upcoming BCL2 inhibitor, where it is a finite therapy that is possible. And this was a CLL14 study design looking at venetoclax with obinutuzumab and comparison with the chlorambucil with obinutuzumab, which is otherwise available in the elderly population. Total number of cycles were given for 28 days cycles were given, and total number of duration of the therapy was 1 year. Now, what we look at here is venetoclax combination with obinutuzumab outperformed the chlorambucil obinutuzumab arm by significant margin at 3 years. If we dissect it further, now we know where exactly we can fit in our population. The one with the IGHV mutation here, even with the chlorambucil obinutuzumab, have done equally well compared to what will be if it is an unmutated one. So in a mutated CLL40, in a mutated elderly patient with newly diagnosed, we have a choice whether they want to go for chlorambucil ibrutinib or with the ibrutinib ibrutinib, depending on which one they want to opt for. In contrast, when we look at the genetic profile of that, the TP53 is going to behave very badly in case we are not using venetoclax up front, and they are the one who got benefited maximum. What additional advantage was the MRD was undetectable in these scenarios. And most of these, what we know from the data available till now, are going to be long-term responders, and it is possible to give a finite duration of therapy in these cases. Adverse events were almost similar between the two groups in terms of hematological conditions. There was no major difference in between the grade 5 adverse event either and between the two groups. So to sum up for the elderly frail population, the newer oral novel therapies like BTK inhibitor and BCL2 inhibitors, they have shown prolonged progression-free survival compared to standard chemoimmunotherapy regimen. The standard guideline now include BTK inhibitor or a BCL2 inhibitor as one of the preferred line of therapy along in combination with the anti-CD20 monoclonal antibody. But in our country, we still have a role of chemoimmunotherapy in those people who cannot go for the more expensive option, particularly in the IGHV mutated CLL. What about younger fit patients? This is an example, 55-year-old with the lower abdominal quadrant discomfort that was coming because mainly of significant splenomegaly. White cell count showed absolute lymphocytosis, total count of 170,000. Platelets were low. Flow cytometry showed typical CLL. Fish revealed deletion 13q. IGHV is mutated. So this patient has all the good risk features that can be there, but he is symptomatic and needs treatment. We start from the basics of CLL-8 trial, which actually compared first time between FCR and FC-arm, which made FCR as a standard line of therapy in these cases. If we look at the long-term follow-up, IGHV mutated FCR did much better compared to FC, and IGHV mutated FCR also did, unmutated FCR also did much better compared to IGHV unmutated FC-arm alone. So FCR by itself became the standard therapy for first line in a young person before the targeted therapy came in. So this became a benchmark on which we have to compare the two. However, we need to keep in mind that this trial showed a difference on a select circumstances based on tolerances. Now, this was a CLL-10 trial, mainly because bendamustine came in. We saw the responses coming with bendamustine as well. So we wanted to check, yes, is it as bendamustine equally good as FCR? So this trial compared head-to-head phase 3 trial, FCR versus bendamustine rituximab in young patients. These are the results for progression-free survival and overall survival. Progression-free survival was superior in terms of FCR. Overall survival did not differ. They were salvageable later on. This trial, again, we have to read the fine lines there. The difference in survival was mainly obvious in those cases who were able to finish the entire lines of therapy, not who had to interrupt it halfway through because of the toxicity. There was more MRD negativity, more adverse events comparatively in FCR arm as per expectation. But for any patients who is tolerating the more intense chemoimmunotherapy, FCR was still a preferred choice. Now the ibrutinib came in, so we have to compare it head-to-head with FCR. So BTK inhibitor with ibrutinib in younger patients. This was a trial with ibrutinib rituximab followed by ibrutinib as a maintenance versus fludarabine E1912 trial. What we have got as an update is progression-free survival was much better compared to ibrutinib rituximab. And what we know here, unmutated IGHV CLL have done much better with this combination of BTK inhibitor compared to what we see with FCR. On the other hand, if we look at the IGHV mutated, they did actually equally well. So FCR still remains a choice, or chemoimmunotherapy remains a choice for IGHV mutated CLL in that scenario and has a potential to provide very long-lasting remission there. Overall survival had a trend toward a better survival in that scenario. If you look at the toxicity expected lines, more hematological toxicity with FCR compared to what we will see, and more atrial fibrillation and bleeding in ibrutinib arm. To sum up, for a young fit person, chemoimmunotherapy shows a promising data. Novel therapies, they show a better result. They are easy to use in terms of oral therapies, but at the same time, they have their own limitations in terms of cost and the preference of the patient, depending on whether they want to opt for it or not. The standard guidelines are now to use targeted therapies. As I said, CIT or chemoimmunotherapy still has some role to play in our setting. Coming to high risk, what do we do for this case? 74-year-old patient, weight loss, fever, night sweats, all the symptoms requiring a therapy in this case. 63-year-old, already treated with FCR. We have seen a long-lasting remission lasting for 9 years. He's a relapse case after that. So FCR already did the job of providing a long-lasting remission. Now the relapse has confirmed it to be a CLL. He's positive for deletion 17p and IGHV is unmutated. So he was one of the lucky ones who got a good duration of response, but now has acquired deletion 17p mutation. There was splenomegaly, but no significant lymph nodes. Now let's look at recapitulate the CLL8 data again. IGHV unmutated even as the first line, and patients did not do very well. So he is in one of those categories where it actually did well and was fortunate enough. Now, when we look at the total number of 17p deletion cases in the same trial, there were very few out of the total enrolled cases of around 800. Approximately 600 were analyzed for the karyotype abnormalities, and 17p deletion was only in 51 of all, and not even a single one entered into a complete remission. So this immediately showed that the chemoimmunotherapy is not the way to go forward in these scenarios. This is a karyotypic data in German CLL study group trial also. Again, if we look at the bendamustine rituximab data on 17p deletion, the curve falls much earlier compared to the one which are showing the better risk profile there. Those with the 11q deletion are in between all the other outcomes. So the 13q is going to be much better compared to 11q versus 17p. So we have already seen unmutated is going to do worse compared to mutated with chemoimmunotherapy. So these are superior. Again, if we look the same alliance trial with the progression-free survival, deletion 17p, 11q, or neither of the two did not change the outcome for ibrutinib at all compared to bendamustine. The curves were entirely different in the first graph when it is 17p, 11q, and even without it, the outcome was almost similar in the ibrutinib arm. So ibrutinib rituximab as a first line does give an option for a long-term control, and it becomes the preferable choice in those with a poor risk genetic profile. Same analysis as per mutated versus unmutated IGHV. What we know there is that ibrutinib provides a better progression-free survival compared to the chemoimmunotherapy, but the mutated one still do quite well. So there it is still a choice. All right, so then we will look at the obinutuzumab venetoclax data, because we have already seen venetoclax can be one of the first line. Should we try that? So this is one of the initial, the CLL14 trial. Again, we have seen that obinutuzumab venetoclax trying compared with chlorambucil obinutuzumab. If we look at the mutation, we have already seen the overlap here in an IGHV mutated one. If we look at the cytogenetic profile, those with the TP53 right there at the bottom compared to those without the mutation. So in those without the mutation of TP53, chlorambucil obinutuzumab, even though it does worse in the terms of progression-free survival, it is still one of the choices for those who cannot go for a ibrutinib-based long-term therapy. Now let's come to the relapsed refractory setting. Resonate was the first trial that was actually gave ibrutinib the name. It was ibrutinib versus ofatumumab. We need to remember this was a relapsed refractory setting where most of the other drugs were used. So ofatumumab was used as a comparative arm. If we look at the outcome, there was no major difference in terms of which karyotypic abnormality was there, whether it was deletion 17p, 11q, or no cytogenetic abnormality at all. All of them were having similar progression-free survival. So basically, BTK inhibitors are nulling the effect of the karyotypic abnormalities as a first-line response. But it is not true over a period of time. They may still lose a response over a period of time and 17p deletion. So we do need to look at if there is any progression of the disease while on therapy. This is again follow-up data in terms of progression-free survival, whether it is complex karyotype or no complex karyotype between the two groups in the ibrutinib, and in terms of IGHV mutated versus unmutated. Let's come to the venetoclax again, which was tried first in Murano trial in terms of relapsed refractory setting. Again, to look at can we have a better response compared to bendamustine rituximab in this scenario? And what we found was the bendamustine rituximab, the venetoclax rituximab arm does much better compared to bendamustine rituximab, wherever there is a 17p deletion or without 17p deletion. And bendamustine, the progression-free survival with bendamustine was much lower. To sum up, for a high-risk CLL, deletion 17p or TP53 is a bad news in case we cannot go for a targeted therapy. The unfavorable prognostic indicators like deletion 11q, IGHV unmutated, complex karyotype, chemoimmunotherapy is not going to be an answer for most of these cases. So we should be trying for a targeted therapy in most of these cases if they are feasible in terms of the cost. The deletion 17p has already got a standard therapy as novel therapies there. In terms of relapsed refractory setting, we have not discussed too much about PA3 kinase inhibitor, but we'll leave it for the panel discussion if anybody would like to discuss it at that point of time. I'll close the discussion here. We can take up some questions, or we can take up along with the panel discussion as per the chairperson. I'll hand it over to Dr. Poonam. Thank you.
Thank you very much, Dr. Ashish. That was a wonderful presentation of what we are actually doing in India, the real world scenario here in India. So there are some questions in the chat box. Is IGVH routinely being tested in India?
Yes, it is available in India, and it is being done for most of the cases now as a standard investigations. It depends on the center's choice whether they want to use it or not, but it is being done, yes.
I don't see any more questions here. So we now go on to the next session, which is a case-based discussion. And this will be moderated by Dr. Sharad Damodar. Dr. Sharad Damodar does not need an introduction, but it's my privilege to introduce him here. He's the clinical director in Majumdar Shaw Medical Center, Narayan Hridayalaya, Narayan Health City, Bangalore, and also the head of hematology and BMT Center at Majumdar Shaw Medical Center. Dr. Sharad Damodar, I welcome you to this session. His panelists are Professor Peter Hillman, Dr. Ashish Dikshit, and there are other panelists which I introduced to you, Dr. Satish. He is again a well-known hematologist here in Bangalore City, a clinical hematologist and hemato-oncologist at Columbia Asia Referral Hospital. Welcome, Dr. Satish. Dr. Mallikarjun Kalashetty, who's again my colleague at Manipal Hospital. He's a consultant in clinical hematology, hemato-oncology, and BMT department at Manipal Comprehensive Cancer Center. Dr. Natraj, he's a consultant hematologist and stem cell transplant physician at Narayan Health City, Bangalore. Welcome, Dr. Natraj. I'm not sure whether Dr. Abraham Burgess is here because I didn't see his name in the list of participants. Is Dr. Abraham Burgess there?
No, ma'am.
Okay, so I hand over to Dr. Sharad to take forward the discussion.
Thank you, ma'am. It's an honor to actually take part in this meeting. I'd like to just add that I think we have Dr. Satish CT also, who's a medical oncologist at HCG Cancer Center. Dr. Satish, are you there? So we have two Satishes.
Okay, sorry. I think I missed him out. I'll just... so sorry, Dr. Satish. Are you there, Dr. Satish? I didn't see his name also. So,
Madam, he's there. He's there. Satish sir is there. Yes.
Okay. So Dr. Satish, he's a medical oncologist at HCG Hospitals, Bangalore. Dr. Satish CT, welcome to this session.
Right. Thank you, ma'am. I think we'll now go ahead with the actual panel discussion. It's an honor to have the panelists on board as introduced by Dr. Poonam Patil, and also an honor to have Professor Peter Hillman as part of this panel. The idea is to just put up a few cases and use this as a platform to kind of bring up more questions and actually discuss what we would do, which is kind of more relevant to the Indian scenario and our practice. So I'll start with the first case, which is directed to Dr. Satish from Columbia Asia. If you can change the next slide, please. Yeah, so basically these are management related questions. So we have a 70-year-old male diagnosed with BCLL, came in with counts of hemoglobin of 10, total count of 46,000, platelet of 95,000. He has generalized lymphadenopathy, cervical, axillary, inguinal region. FISH shows trisomy 21. So I was just trying to highlight the point and actually ask the question whether, we are doing this routinely. Now in India, I think most people do FISH, and they also now have started ordering for the IGVH mutation. So as we discuss, we'll come to that. So if you look at comorbidities, that's another issue. We tend to have more elderly patients. So they could have had a CABG. In this particular case, he has hypertension, hyperlipidemia, and BPH. He was started on chemoimmunotherapy, and for this case, we will consider that as bendamustine rituximab, which is the commonest used in our setup. 1 year later, he has clinically meaningful improvement. In the meantime, he takes another opinion, meets a few other hematologists, and now he has another FISH report, which is showing deletion 17p positive. Next slide. So the questions are, the first question. So to Dr. Satish, how will you manage the patient now? And what are your thoughts on looking at BTK at this point in time, or do you want to wait and watch? Dr. Satish.
Thank you, Dr. Sharad. Thank you, Poonam madam, for the kind introduction. So Dr. Sharad, this patient, we didn't know that he had deletion 17p in the initial setting. So he has been treated with BR, which is the commonest regimen we use for CLL in most of our patients. Before we were using IGHV mutation and TP53 mutation analysis. Usually FISH comes negative for deletion 17p. We used to start most of the patients on BR. So this patient, though he has later been detected to have 17p deletion, because he has achieved a meaningful remission, I assume by response criteria, if he has achieved at least a partial remission, if his CBC is good and he doesn't have any symptoms, I would manage him just by close observation. I will follow up closely every 3 months. So because we know that even 17p deletion patients, suppose they are detected de novo, without any treatment, we can closely observe for at least 2 to 3 years. Only 50% of them need treatment at the end of 3 years. So even though this patient has had an indication initially, treated with PR, now if he's in meaningful remission, I think I would just closely observe him and wait till progression.
And then when he does progress, what would you consider, Satish?
Definitely, my choice would be BTK inhibitor or venetoclax, because it's seen that in patients with 17p deletion, because venetoclax has been approved for a finite therapy for 17p deletion and TP53 mutation patients. If you use venetoclax based therapy, we have to stop at 1 to 2 years, and many of them progress. So I would prefer an indefinite therapy with ibrutinib / acalabrutinib when he progresses, Sharad. Coming to the choice of ibrutinib versus acalabrutinib, if his hypertension is well controlled, if his echo is normal, if his ECG doesn't show any changes, then I would prefer ibrutinib also. But yes, if his hypertension is not well controlled, I would definitely prefer acalabrutinib over ibrutinib.
Okay, we'll go on to Dr. Peter Hillman for his thoughts on this case before I put him in some more questions. Dr. Peter, your thoughts on this particular patient?
Thank you, Sharat. I agree in terms of observation. I mean, it's sometimes a challenge when patients get their FISH done, not when treatment's not required, because it just creates more stress for everybody involved, including the patient. So that's a challenge. But he must have had a reasonable amount of disease there to get a 17p result. So it's likely he won't be in remission for too long, but I wouldn't treat him until he needed treatment conventionally. I also agree that I would prefer a continuous therapy in someone with a proven 17p deletion. We would also do TP53 mutation analysis with next generation sequencing. I think there are a small proportion of patients who will be mutated and not deleted, and so it's important to remember that if chemotherapy is still an option in your community or generally. I would slightly differ that I think in someone, because he's had a coronary artery bypass graft before, he's hypertensive, he's clearly got cardiac issues, even if it's well controlled, and I am anxious over ibrutinib in that setting. I would speak to the patient, obviously, and I think that I would probably favour acalabrutinib in that patient with proven cardiac abnormalities previously. You could also make a case for venetoclax because of the cardiac abnormalities, but I think, and certainly before we had acalab available, that might have swayed you towards a ven-based regime. Yeah, that's the only difference.
Okay, so just a thought on this, Dr. Peter. So when somebody's undergone a CABG, they would definitely be on antiplatelets. Certainly on one for sure. Sometimes, if they're just coming off straight away post procedure, they would be on dual antiplatelets. So what is your thought when you have to introduce a BTK inhibitor? If they're already on an antiplatelet, would you take that off totally, or would you kind of cut down dose? Your thoughts on that?
Yeah, so we've had some quite interesting conversations with the cardiologists in this setting, who are very keen on double platelet antiplatelet therapy, certainly post stents, for example, or soon after a stent. Right. Our experience of using aspirin plus ibrutinib or acalabrutinib is generally fine. They will bruise a bit more, but it's certainly a patient who's on aspirin for good reason. I would continue the aspirin with the introduction of BTK inhibitor. If they're on a double antiplatelet drug plus a BTK inhibitor, that's more of a concern, because these patients really do bleed and bruise quite badly. So I'm very anxious about the clopidogrel plus aspirin plus a BTK inhibitor of any type. And in the patients that we've had one or two like that who've had a stent usually put in, and they need double antiplatelet therapy for a month minimum, maybe 3 months. We've generally left the BTK until they've been able to go down to a single antiplatelet drug, and then added the BTK with a bit of negotiation with the cardiologist as to how quickly we can get them off the BTK, the double platelet antiplatelet therapy. Often in that setting, the patient's been on a BTK for a period of time and is in a good remission, and we know from ECOG and trial and from other experience that if a patient's in a good remission from a BTK inhibitor and they stop for toxicity, it's an average of an ECOG of almost 2 years before they progress. So you have got some time to play with if a patient's in a good remission.
Right. Thank you so much for your thoughts, Dr. Peter. We will now move on to the second case, and this is addressed to Dr. Mallikarjun. So this is a 54-year-old male, diagnosed BCLL, a very active citizen, runs a marathon, I think just like Mallikarjun. Hemoglobin is 12, total count 36,000, platelet of 1,80,000. Significant lymphadenopathy. He's got a beta 2M of 3, mildly elevated. His marrow shows 80% lymphocytes, the diffuse pattern described on the biopsy. He is IGHV mutated and he's deletion 17p positive. Next slide. So questions to Dr. Malik first. How will you manage this patient? And the subsequent question, what would be your treatment of choice and the rationale behind it? And do we have a third part to this question? No, okay. Yeah, Dr. Malik, your thoughts on this?
Good evening, sir. Good evening, everyone. Thank you for having me. So obviously, this is a young and very fit patient. Not sure if I'm as fit. So essentially, high risk CLL is the deletion 17p, young and fit, no comorbid illnesses. So obviously, the first question we always ask is there any indication for therapy? Does he have constitutional symptoms, bulky disease, or cytopenias, or any other indication? So if there are no indications for treatment, would still put him on surveillance and then keep watching him over. Now, if he develops any of disease therapy related indications for treatment, then we'll obviously look at the options. And we all know individuals with high risk CLL with 17p deletion would do very poorly with any of chemo or chemoimmunotherapy. So we would use targeted agents. And the choices again we have are ibrutinib, acalabrutinib as single agent, or combination with obinutuzumab or rituximab, or venetoclax with obinutuzumab. So individually, I would prefer using a single agent BTK inhibitor. And if acalabrutinib is available, I would prefer that with regards to better toxicity profile, tolerance, and perhaps less serious bleeding complications, sir.
So Dr. Malik, since he's a fit 52-year-old marathon runner, would you ever bring up the possibility of talking about a transplant?
So I would say if it does well with one of these agents, I would certainly not consider transplant in first remission, and perhaps wait for him to progress or have a relapse, and then think about it.
Okay, so we'll get Dr. Peter's thoughts on this. So the same questions to you, including the transplant question, Dr. Peter.
Yeah, I agree. I mean, he should be treated when he needs treatment, because some patients with 17p can go for years without needing therapy. So he has got lymphadenopathy, so he's likely to go on to need treatment soon. I prefer, again, indefinite, sort of continuous therapy with a BTK inhibitor. We've used ibrutinib in this setting, and I think he's fit. We probably would at the moment until we see the head-to-head trials. In terms of transplant, I would speak to the patient about transplant. I mentioned transplant at the time of starting to treat a patient, but would not consider it as a treatment option now. If he starts to relapse through his BTK inhibitor, then I think you then seriously have to consider when the transplant would fit in. Usually, if they didn't respond well to venetoclax in second line. The other things that are changing in this group of patients are we've actually got 2 trials open at the moment in Leeds for these patients with combinations of a BTK and a BCL2, and so that may be an option going forward, and certainly for our patients in trials, to stop therapy with deep remissions, because we're seeing deep remissions. And the other development that's happening is CAR T. So although we talk about transplant, and it may be that this sort of patient eventually would end up having an allogeneic transplant because they may not be controlled by BTK for years and years, CAR T may well take over from that. So delaying the transplant while all these other things are developed, combinations and CAR T, is probably sensible.
Yeah, so there's one more question on the chat box on the same patient. So in this person, would you then consider finite therapy with venetoclax, because he is high risk, and then there's also a cost element which is going to be involved when we are discussing infinite therapy. So your thoughts on this, Dr. Peter, an option of offering venetoclax?
I think personally I wouldn't, with the data we have at the moment. You saw the data in terms of the CLL14, where the patients are actually relapsing even during the venetoclax 12 months, and a third of patients relapsed by 2 years. So we know in that 17p deleted, p53 mutated CLL is effectively genetically unstable CLL. That's the way I think about it. And so they are likely to clonally evolve. And what we want to do is use our best treatment frontline, because we know that they become more difficult to treat when they relapse through one line of therapy, regardless of what that therapy is. And so treating someone for a year, for example, with VEN-O, allowing them to relapse a year later, and they're less likely to have a good response to a BTK inhibitor at that point. And so I think I would use the best treatment, which I think is at the moment for the phase 3 of BTK monotherapy, although that's why I for this particular group of patients, I think trials of the combinations is really critical, because I think if we're getting the majority MRD negative, then we have the best chance of having a prolonged effect on the disease. So no, I wouldn't use a VEN unless the patient had major issues with ibrutinib or acalabrutinib. Financial may also be an issue, I guess, as you alluded to. I think if really it's not feasible to have an indefinite use of BTK inhibitor for an individual patient, then venetoclax obinutuzumab is a reasonable. It's better than chemotherapy, certainly, and better than CAMPATH-based treatment. But half the patients, at least, will not have a very good prolonged remission from that approach.
Right. Yeah, in our country, I mean, currently at the cost of acalabrutinib, if you have to give it for 1 or 2 years, that would equate the cost of an allogeneic stem cell transplant. So that's where some of these things become a factor when we need to take that call, and that's why I kind of deliberately brought up the transplant issue, because cost becomes an issue when you need to talk about infinite therapy.
Entirely. I mean, we're in a fortunate situation that individual cost of the patient is not an issue for us, because it's all covered by the health service. I mean, sometimes we have problems getting drugs approved, but I think in the context, if there really was a financial imperative where you couldn't give indefinite BTK, then and a transplant was an option, a VEN-based regime to get to remission and then a transplant is a reasonable option, although we don't have a lot of evidence from trials.
Right. Yeah. Thank you so much. Right. We'll go on to the third case. This is to Dr. Nataraj. So, Dr. Nataraj, we have a 74-year-old female, BCLL, deletion 11q, IGHV status unknown, which is pretty common in our country. Again, treated with 3 cycles of BR and then discontinued due to toxicity. This is again a common phenomenon, which we see people, it's a compliance issue. So they're citing nausea and diarrhea here, got discharged on request, then again comes back to the clinic after 3 months with complaints of B symptoms. So this is a common scenario in our country. Then comes back with a hemoglobin of 9, total count of 55,000, a platelet of 70,000. She's also been a diabetic for about 20 years. So this is how she presents back to the clinic. We'll go on to the next slide for the questions. So the first question is, what additional diagnostic tests will you recommend when she comes back 3 months after losing follow-up? Will you reconsider this patient with chemoimmunotherapy, which is either BR or whatever else? If no, would you consider BTKI as treatment of choice, and what would you then look at? So Dr. Nataraj, these questions are for you.
Thank you, sir. Thank you for having me in the meeting. What additional diagnostics tests will you recommend whenever we restart the patient on treatment? Whenever patient comes back with a re-indication, we should always repeat the FISH, and then if available, molecular based 17p deletion tests. And irrespective of whether the patient has got whatever the molecular features, I don't think this patient should be treated with chemoimmunotherapy, number one. And second thing is, I would definitely do an IGHV mutation analysis for this patient. These are the 2 things which I would do. And third thing is, since she has come back with B symptoms, I don't think it is purely immune related. So I think these 2 tests I will do. And will you re-challenge this patient with CIT? Unlikely. Most likely I will not re-challenge this patient with CIT, because for 2 reasons. One is 17p deletion 11q patients will not do very well with chemoimmunotherapy. And second thing is, already she has developed adverse effects which has limited her continuation of treatment. Probably even if you give CIT again, she may take for 1 or 2 cycles and she may disappear again. And if you consider BTKI, which would be your preference? If caste is not an issue, then acalabrutinib would be a preferred therapy in India. But if caste is a constraint, then I think I would still go ahead with ibrutinib. because ibrutinib comes at 20,000 rupees a month cost, and then Acal will come with about 1.2 or 1.3 lakhs a month cost. And both are infinite treatments. There is no end to it.
Okay,
And I know that there will be a lot of cardiac effects.
Yeah, so now I will add two more questions back to Nataraj based on what he has said. So first is, you did the IGVH mutation and the mutation came back as mutated. Okay, that's the first scenario. And second, would you be comfortable using generic ibrutinib if you wanted to use it when the patient came back as IGVH unmutated?
Sir, irrespective of IGVH mutated or unmutated, maybe this patient would be still, I would still prefer to be started on BTK inhibitor based therapy. And second thing is, whether will I use ibrutinib or acalabrutinib, whether it's generic versus the innovator. Innovator ibrutinib is as expensive as acalabrutinib. Of course, if somebody can afford a innovator in ibrutinib, they should be able to afford acalabrutinib. I would definitely, at that point of time, I would use acalabrutinib over ibrutinib for this patient. Generic ibrutinib, yes, it's a good choice because it's about 20% of patients who develop all these side effects with BTK inhibitor, generic ibrutinib at this age with serious limiting serious side effects. Remaining 80% would still go on. So if it's better to give something rather than doing nothing, or just re-challenging this patient on chemoimmunotherapy, sir.
Right. So now I'll pose the questions to Dr. Peter. So Dr. Peter, what are your thoughts on the additional diagnostic tests when somebody comes back like this, and how would you kind of use that to take a call on the therapy?
So I'm going to answer the question the other way around, if that's all right, Sharat, because I think it's more logical. So question 2, I would not re-expose this patient to chemotherapy. So she's already failed BR very quickly. She's had 3 cycles. And so even, I would avoid giving chemotherapy even frontline, but in this setting, 11q deleted, failed BR, I'd go for a targeted treatment. So then the question is, which targeted treatment would you give? Well, I think, on the face of it, you've got the choice of a BTK inhibitor or venetoclax rituximab would be approved. And so if there are options, if there's still options to the patient, and obviously depends what's available to the patient, where they are from a financial point of view, I think then the diagnostic test will allow you to choose which of those treatments to choose. So so let's assume they're both available, venetoclax or a BTK inhibitor, then if they're 17p deleted, I would go for a BTK inhibitor without a doubt. I think that's fair. If they're VH mutated, but not 17p, not PPD mutated, then I think a ven-based regime is reasonable because you're more likely to get a long period of time off treatment, but that she's most likely going to be VH unmutated because she's 11q deleted and they co-segregate. So if she's unmutated, I think there still is a choice between ven or BTK, and that's a patient choice, really, after discussion. In terms of which BTK inhibitor, at the moment, from the data that's available publicly, either are reasonable. I don't have any experience with the generic ibrutinib. Assuming it's equally effective as branded ibrutinib, then if it's significantly cheaper, then I might go for ibrutinib. In someone without a cardiac history. She's got diabetes. She has risk factors. She's female, which in our experience is a good thing in terms of toxicity, but cardiac toxicity. So I think it's reasonable to go with ibrutinib or Acala. I can't really speak about the trials coming through, but I suspect that might change in the next few months when we see some of the data with the head-to-head comparison. But at the moment, we don't have that data. And so that would be my thoughts, really.
Right. So, Dr. Peter, are you all routinely doing IGVH mutation testing now at diagnosis in all patients?
Yeah, it's part of our guidelines, so we would definitely do it before treatment. And most patients, it's actually the most useful test after the flow to diagnose CLL in stage A disease to define whether the patient's going to progress to treatment or not. 90% of our patients in our practice present with stage A disease, so it's the biggest group of patients. And when we ask our patients, and we've done this, we've surveyed patients in the UK, the most common and most stressful situation is stage A disease, the watch and wait. There's more patients worrying about it. And I think there's a good justification for doing mutational status, because if the ones who are mutated, it's reasonable to do less frequent monitoring and to reassure them that many patients won't go on to ever need treatment, whereas the unmutated are watched more closely. I don't think every patient in the UK gets it, but it is available for them.
Right, right. Thank you so much for that input. We'll go on to the fourth case. This is directed to Dr. Satish CT. So this is a younger patient, a 38-year-old man diagnosed 1 year ago with CLL. Experiences a very rapid elevation in peripheral blood leukocyte numbers, which kind of jump from 20,000 to 2 lakh within the first year. So kind of very aggressive. Spleen large, palpable, occupying the entire left side of the abdomen and crossing onto the right side of the pelvis. He has notable generalized lymphadenopathy. And the patient's prognostic markers indicate an unfavorable prognosis in the form of an unmutated IGVH as well as trisomy 12. However, he does not have the 17p. Next slide. So the questions which come up are, how will you manage this patient, a young fellow? We're moving away from the usual elderly patient. Would you consider finite treatment or treatment till progression? And how would you kind of fit this in? If you have the option of chemoimmunotherapy, BTK and BCL2, what would be your choice and why? And like I mentioned earlier, would you even start considering a possible transplant for this particular patient, Dr. Satish?
Thank you, sir, having me as a panelist. Sir, like this case, definitely is progressing very fast and unfavorable markers are there, molecular marker, like except 17 P deletion. Like this case definitely is a clinically progressing and massive splenomegaly requires a treatment. One of the treatment like there chemoimmunotherapy, this is the decision. Because young fellow, like I'll try to go for FCR is one of the option. I'll try to go. Like is a fit person, I try to go. Like not finite treatment, I'll try to try. If the patient like like I'll try to see the like if anything is a progression is there, definitely I'll try to consider for the because the BTK is one of the option is a day one I will discuss with them. But only thing is like about the cost of the treatment for like now generics are there, but the patient is not willing to continue the treatment at all for until it is a progression. I'll try to consider a couple of cycle of here as a regimen and try to have a maintenance therapy. That's what.
So would you bring up the option of venetoclax based finite therapy also in this particular setup?
Sir, like definitely I want to consider, sir. The only thing is personal experience of
okay. And
using
you also
yes, sir.
Yeah. Go ahead.
So personal experience of like venetoclax is I not experienced except AML. One of the patient we have combined with done, but in CLL I could not able to use it.
Okay.
BTK inhibitor I definitely having except Acalabrutinib. Yes.
Right. And would you also possibly then consider keeping a backup plan for stem cell transplant, keeping HLA typing and all that?
Yeah, definitely. So I'll keep this patient. I'll try to assess the response to the like some depth in the patient require a BTK inhibitor some point of time. Because the patient is very young, like requires like unfavorable prognosis factor is definitely I'll try to keep as a stem cell transplant is one of the option because the problem is issue with the continuation because generics I can able to go ibrutinib, but some point of time even may progress on this one also. But I don't think the patient is able to afford all for acalabrutinib. Definitely, I may keep the option. Otherwise, stem cell is one of the considered day one. I will be explained because like a patient will do the way is disease progression is happening from the within first year is progressing fast. He'll respond to the treatment or like whatever treatment you choose, but we have to see the how durable response patient is doing too well. But some point of the time the patient requires stem cell transplant. That's one of the things family will be concerned from the day one. That's what is my side. So.
Okay, right. Dr. Peter, if this patient was in the UK, how would you kind of manage this patient?
This patient is, to me, a very worrying patient. So much worse than the other ones. I mean, he's a young gentleman. He's got extremely proliferative disease. He's got a doubling time of around 3 months from 20 to 200. He's got a massive spleen. So he's got very bulky disease. We know that from our studies and others that there's a small proportion of patients that really have bad risk CLL or complex karyotype, are very proliferative, and this is the sort of patient we tend to see who are like that. I also worry a little bit more about trisomy 12. I know in the trials it's not a majorly bad thing, but you know, the bad things happen to. I've seen 1 or 2 patients with trisomy 12 that have done badly. So I think he's one that I would be really anxious about. In view of the proliferative nature of disease and the bulk disease, I would, in the first instance, go with a BTK inhibitor with him. I think he's got very proliferative disease. I would worry that, and I'd want to be certain that he had CLL, not mantle cell, just to make sure that he doesn't have a more aggressive lymphoproliferative disease.
Right.
Probably not with the trisomy 12, but I would certainly want to know that he didn't have 1114 and he was cyclin D1 not translocated. So let's say he isn't. I have a slight anxiety with the Veno would be the treatment. It would be approved in the UK for him, but the chance of him going into a complete remission with no palpable disease, spleen normal, would be pretty small probably, because if you look at the studies, we don't have the entirely comparable data, but at 9 months with VR in Murano, many patients have local lymph nodes still, and it takes longer for the disease to go down under control. So I would favor BTK, but I would also think that he is likely to fail sooner or later, and we would be thinking of transplant. He's 38, so he's not, he's 10 years in remission is not good enough for him. It might be if you're 80. So I'd be talking to him about that. I think he's the sort of patient where combination therapies would in the future be approached, likely to be beneficial. BTK plus BCL2. I wouldn't go near chemotherapy with him, and maybe even a CAR T eventually. But he would worry me. NGS might help. So we do high-throughput sequencing panels on our patients, which includes TP53, but also about 23 other genes, lymphoid genes. And if you see multiple mutations, then that would be a worry, because he's already clonally diversifying and evolving already before he's treated. So yeah, this is one of the ones that would worry me.
Right. So, I mean, just to add another thing, so if he had a matched sibling donor, would you kind of go the allogenic transplant route, or would you still look at CAR T cell therapy prior to?
No, I think what I would do in that situation is I would give him a BTK, because he may well respond well, and if he does, that's his best option at the moment. If he doesn't respond well to that or fails that, then I think I would go at the moment for allogeneic transplant. So we CAR Ts are a challenge now in CLL. We've just got some data with Lysocell. The other 2 products, we don't get T cells from them. So I think, and we know that the only curative treatment we have thus far is an allogeneic transplant. If he's got, same with a sibling, but even with an unrelated donor, if he's failed a BTK and he's got a well-matched donor, I would go for a Ven-based combination next. If he's MRD negative, I think you can then discuss whether you don't do a transplant. You watch him. If he's MRD positive at the end of a Ven-R, then I think he's destined to relapse and should be transplanted at that point. And then CAR T can be reserved for later on if needed. Hopefully won't be needed. But I think, he's 1% of our CLL patients probably, but he's a worrying 1%.
Right. Right. Yeah. So we won't waste more time on this. We may have time for just one last little case. I think, yes, we have about 3 minutes left. So the last case, I'll give it to Dr. Ashish Dixit, who's done the discussion so far. So this is a 72-year-old male, active lifestyle, diagnosed BCLL. He's got palpable adenopathy. 5 years after his diagnosis, develops bulky adenopathy with larger lymph nodes, and total count of 45,000 fishes, deletion 11q. Treated with 6 cycles of BR, then treatment stopped when clinically visible disease disappears. He tolerates it well, counts have reduced. And 4 months after the last cycle, his hemoglobin platelets have normalized. Now, 8 years later, when he's 80-year-old from his original diagnosis, he comes back with similar signs of bulky adenopathy. So, Ashish, your thoughts on this before we quickly wrap up?
Again, we'll go by the basics again. We'll need to do a FISH test and then check whether he has the same phenotype or not in terms of the same genotype. In fact, it is deletion 11q. In case I need to use, I'll still prefer to use, if it is 17p deletion negative, I'll prefer to use BTK inhibitor based therapy, because the main problem here is mainly the bulky nodes that are mainly prompting the patient for the therapy if the counts are fine. So that will be the preferred way to go. In case he needs therapy, symptomatic and bulky adenopathy is the main reason.
Right. So, Dr. Peter, your thoughts on that?
Yeah, I think well, he's had we don't like, I don't personally like BR in CLL, so I tend to use FCR or calamus stabilities in the days where we actually have targeted treatment. For this particular patient, he's had a very long remission after BR. He had 8 years off treatment, so he's probably reasonably good risk in those terms, because that's twice as long or more than twice as long as the average. I think you could certainly make a case for venetoclax-based treatment, because there's a reasonable chance you'd have 2 years of VEN-R and then more than 2 years off treatment if you achieved MRD negativity. So I think it's a discussion between you and the patient as to what approach he wants. The only concern I'd say at the moment with COVID, it leans me towards a BTK. But if you took COVID out of the equation we went in that era, then I think a VEN-R is a reasonable approach to someone like him.
Yeah. So, Dr. Peter, your thoughts on the toxicity of VEN-R, because I mean we don't seem to have used too much of it. Most of us are being comfortable using ibrutinib. So, is it a very toxic regimen in the elderly, the venetoclax?
No, it isn't. The issue is the tumor lysis, but that's manageable. We only see 2 or 3% of patients. We've used a lot of it. When you get experience using it, it's not that difficult to do. It just means a lot of visits to hospital in the first month. That's the challenge. And actually, in terms of the ongoing toxicity, that you don't see the ibrutinib nuisance side effects. You see a bit of diarrhea, a bit of flatulence sometimes, and you see a little bit of neutropenia, particularly with the CD20, but that usually G-CSF responsive. So no, I don't think there's a major issue with toxicity.
Okay, right. Great. I think thank you so much for your time and all your inputs, Dr. Peter, and all the panelists. I think we're just bang on time. We'll end the discussion here, and I'll hand it back to the chairperson. Thank you so much.
Thank you very much, Dr. Sharad. It was a real nice discussion and sharing of cases and everybody's opinion. There is one question from the audience. Let me take that one question. Any difference in management of TP53 mutated and 17p deleted cases of CLL? Dr. Sharad, you can only take and answer this question.
Yeah, so I think throughout our discussion, we have been, highlighting what happens when you have, either of them pop up. And I think Dr. Peter showed us all the data when he's broken down all the cases, and what percentage have the 17p versus the TP53. In a subset, the TP53 was higher. And they would eventually fall into that same basket where they are high risk. They would tend to progress faster. And like we discussed already, if they are absolutely well and asymptomatic, you could hold. But the moment they start progressing, you need to intervene. And then you would probably go the ibrutinib or the venetoclax route there. Again, your IGVH mutation might help. But clearly, you're not going to be doing the chemoimmunotherapy in that subset of patient. I think that's very clear from all the presentations and discussions so far. I think that would be the take-home point for that subset of patients.
Thank you very much. Thank you very much, all of you, for having given your time for this discussion. And I think as we all improve our experience with acalabrutinib, maybe we will be wiser with time. And with this, I close the session today. Hand over to Dr. from AstraZeneca. And thank you very much, Dr. Peter Hillman. Thank you very much, Dr. Ashish, Dr. Sharad, Dr. Mallikarjun, Dr. CT, Dr. Satish Kumar. Thank you very much.
Thank you so much.
Thank you very much, ma'am. I would like to thank Dr. Professor Peter Hillman for joining us today. Dr. Poonam Patil, ma'am, thank you very much for moderating this session and also chairing the panel discussion. I also thank Dr. Ashish Dikshit for his valuable inputs on the Indian context of CLL and the treatment management in India. I thank Dr. Sharad Damodar and all the panel members for their wonderful discussion during the case-based discussions that happened just now. I hope the audience had a good time learning new things from our panel members. And also, I would like to thank the audience for their time. It was a long 2 hours of peaceful learning about CLL in Indian context, as well as the new molecules which Professor Peter Hillman had discussed about. And last but not the least, I would like to thank Mice Ideas for giving us this platform and making this event run very smoothly. Thank you all. Thank you once again. Have a pleasant evening. Bye-bye.
Take care.